A warm welcome to one and all. This is Dr. Sunil Manuel, Associate Professor from the Department of Orthopedics at SDM Medical College, Dharwad. Today I come before you with a recorded lecture on the examination of the wrist. So from now on, there will be a slight change in the voice quality because what you'll be hearing is the recording from the classroom. Now I have a picture of the upper limb here. So the picture of this upper limb is basically put here to tell you that whenever we are dealing with a shoulder examination or an elbow examination or the wrist examination or my favorite topic, which would be the hand examination. Whenever you're dealing with any one of these examination, you cannot see one part singly. You'll have to see the entire upper limb as a whole. That is because pathology of one part can cause some disturbances in the functioning of the other joints. So if you have a wrist problem, then there are going to be some changes in the elbow or some functional changes in the elbow. I would say there may not be structural changes in the elbow, but there will be functional changes. So when we are seeing a wrist examination, for your convenience and to make it easy for you and clear for you, that is the only reason why I am dealing only with wrist. But there are so many things about the elbow that you should be knowing. There are so many things about the shoulder that you should be knowing, and you have to synthesize and bring all these things together so that you see the whole upper limb as a whole. So that is the point that I wanted to emphasize. So don't think that okay, wrist examination means I'll just look at the wrist. No, you're going to see the patient as a whole, because there are so many points in the upper limb which is going to give you more information regarding the wrist examination. So I will give you some specific examples later, but I think I've made my point pretty clear. So so this is what I really like in clinical examination. So whenever we teach clinical examination, we always, as teachers, especially final year teachers or clinical teachers, we do have an assumption that all of you know your anatomy very well. This anatomy, understanding this anatomy is what is going to help you understand the clinical examination. So this of course is the anterior view of the wrist. You can see the distal radius and the distal ulna here, and you have the entire carpus that she looks two pretty kind of bones. Now I want to tell you that when you think of the wrist joint, you are actually thinking of this articulation between the radius ulna and the proximal carpal row, but technically that is wrong. The wrist encompasses the radiocarpal joint, the joint between the ulna and the articular plate, I'll show you that later, and the intercarpal joint. So this whole structure here put together becomes the wrist. So that is what you should understand as far as clinical examination is concerned. Maybe when somebody tells you about the theory, theoretically you can say the radiocarpal joint, but clinically we are seeing this entire thing, and this entire mass acts as one. So that is something that you should understand. So obviously what you are seeing here is that the distal radius articulates with the scaphoid and with the lunate. So the undersurface of the distal radius has got two notches. One notch that articulates with the scaphoid and the second notch that articulates with the lunate. But you see this distal ulna, it is of course articulating with the distal radius to form the distal radio-ulnar joint, but then it doesn't seem to be articulating with any of the bones directly. That is in anatomical position. So what does this mean? Does this mean that there is an empty space here? No. What is there in that space? I will tell you. There is a joint in that space. However, it is not an articulation between a bone and another bone. That's the funny part about that joint. Okay. So coming to the posterior surface, there is nothing more to tell. I just want you to appreciate this structure here that is called the radial styloid. You've all heard of this structure, radial styloid process. And I want you all to run your hands on your own wrist on the lateral side and feel the radial styloid process. And coming to the medial side, you have the similar process on the distal ulna, that is called the ulnar styloid process. And this structure here is called the Lister's tubercle. Okay, or here Dr. Manetta has mentioned it as dorsal tubercle, but I would call it the Lister's tubercle. It's an important structure. In fact, with a little bit of difficulty, you will be also able to palpate the Lister's tubercle on the dorsal surface or the posterior surface of the wrist. Okay, so this is the cut section of the wrist joint, and this is what I actually tried to emphasize to you, that the whole thing forms a single joint. That is the radiocarpal articulation, and this is the articular plate that I told you. That is the articular disc. It's a cartilaginous disc with which the distal ulna is articulating. So distal ulna is not directly articulating with any bone, but there is a nice disc, and later on I'll tell you a few more things about the disc. And also you will see that there are a lot of intercarpal joints here sitting together, and all these intercarpal joints sitting together, and this whole mass here forms the wrist joint. There are so many ligaments. I'm sure even I cannot answer or name all of these ligaments, but I've just put this picture here so that you understand that the wrist is essentially a very solid and stable joint. What I also want you to understand is, in between these bones also there are multiple small ligaments that is holding up everything, and from the distal radius and the distal ulna also there are a lot of ligaments that are holding up things. So this is the volar surface, but the limited point that I want to tell the student is that the wrist is underlying a very stable joint. So it is well held by ligaments. Why am I telling this? I am telling this because you learnt about the shoulder joint, or you must have heard about the shoulder joint, that the shoulder joint is inherently a very unstable joint. Why is it an unstable joint? Because it is giving you so much of mobility at the price of stability, at the risk of not being stable. The reverse for the hip joint. The hip joint gives limited mobility but gives you good stability. Similarly, the wrist joint also does not give great amount of mobility, because you don't need a great amount of mobility also. However, the wrist joint is inherently a very stable joint, and this is what I want, the message that I want the student to take back. Coming to the articular disc. So I told you about the articular disc that I said is the one that the distal ulna articulates. So here this picture, when you see that the distal ulna, this area, it articulates with a disc that moves from just above the lunate and all the way up till the ulnar styloid process. So this is called the articular disc. So though there is a curve like this, it is actually maintained like this because of the articular surface. That's because our proximal row of the carpal bones, they curve in a U-shaped direction. But the distal radius and the distal ulna don't have that U-shaped curve. And to make up for that U-shaped curve, you have this structure called the articular disc. So I want you to understand that the distal ulna, apart from articulating with the distal radius to form the distal radio-ulnar joint, also articulates with the articular disc and does not directly articulate with the bones of the carpus. So in other words, sometimes we use this word called radiocarpal joint. Is another word that some authorities use for the wrist joint. By using the word radiocarpal joint, they are actually meaning the wrist joint, and they are also trying to mean that the ulna does not articulate with the bones of the carpus. It is actually the radius that articulates with the bones of the carpus. Okay, so this is a very beautiful picture of the undersurface. So undersurface of the distal radius. So this is the lateral side, this is the distal radius, and here somewhere behind is the ulna. So you will see on the lateral surface, on the radius undersurface, you have this articular cartilage into which the scaphoid articulates, and this articular cartilage, another notch here, into which the lunate articulates. So that is how the distal radius articulates with the scaphoid and the lunate. So scaphoid, lunate. Scaphoid articulating with the lateral notch of the distal radius, and the lunate articulating with the medial notch of the distal radius. Now coming to the articular plate, this is what the articular plate looks like, or the articular disc looks like, and the distal ulna is basically articulating with the articular disc, which, so overall it gives a nice gentle curve. As you can see, it gives a gentle curve here as compared to the acute curve produced by the carpal bones. Okay, so why is this important? This is important because this will give the patient good amount of ulnar deviation. So you know, there is something called I'll be explaining ulnar deviation, radial deviation to you. The radial deviation is limited because of the styloid process, And we also see that the styloid process, the distal end of the styloid process, radial styloid process, is distal to the distal end of the ulnar styloid process. Therefore, our radial deviation is very limited. So beyond a certain level, you cannot go. But the articular disc ensures that we have good amount of ulnar deviation, and that helps in some activities. Okay, so this is another picture of how the articular disc looks from below. Okay, so all this I am telling you because I want you to understand that there is a structure called the triangular fibrocartilage complex, or the TFCC. So when I was a student of anatomy, when I was an MBBS student, we had never heard of this structure called the triangular fibrocartilage complex. So the articular disc was of course named, and some other few ligaments were named. But this terminology, triangular fibrocartilage complex, refers to a triangular area of fibrous tissue, ligaments and cartilage and the articular disc. So this triangular area, this whole thing gives the medial support to the wrist. Okay, so that's the medial stabilizing structure. What is the surgical importance of this TFCC? We call it the TFCC. So what is the surgical importance of the TFCC? Lots and lots of patients come with strains. So what do I mean by a strain? A strain is a tear or an injury. Sprains. A sprain is a tear or an injury in a ligament. And what is a strain? A strain is a tear or an injury in a muscle. So normally, now we are only talking about ligaments here. We are not talking about muscle. So lot of patients come with sprains in this area because of some kind of injuries, and they come with a peculiar condition called ulnar sided wrist pain. I do see a lot of medical students also coming to me with ulnar sided wrist pain. The chief reason for ulnar sided wrist pain is so it is not a generalized wrist pain. It is a ulnar styloid wrist pain, and this ulnar styloid wrist pain is happening because of the sprain of the triangular fibrocartilage complex. So that is what I want you to understand here. Okay, now you see the X-ray in perspective, and now you can see this whole gap here. So all these years, I don't know whether you've been seeing X-rays very regularly, but you'll notice that this whole area appears to be very empty. But now as a student, you know that this area is filled with the strong triangular fibrocartilage complex along with the articular disc. So all these things are basically cartilaginous or fibrous, and therefore they do not appear on the X-ray, because the X-ray is only looking for radio opaque structures like bones, and therefore this whole area now appears empty. So whenever we see a patient with ulnar styloid wrist pain, we are looking for edema in this area, which will be seen by bulge in this area, and also we are looking whether there is any injury to the distal to the ulnar styloid. Okay, so we have the volar structures here. So coming to the structures on the volar aspect of the wrist and the structures on the dorsal aspect of the wrist. Now these are the volar structures. So basically there are some structures on the volar side of the wrist. So the structures on the volar side of the wrist are the chief structure that we have is the volar carpal ligament, or we can also call it as the carpal or the transverse carpal ligament. So that ligament makes it have a tunnel that is called the carpal tunnel, in which the tendons, the main flexor tendons, are all housed along with a very important structure called the median nerve. So if there is any increased pressure within this carpal tunnel, then the median nerve gets compressed, and therefore what will happen is you will have a carpal tunnel syndrome. You must have heard of a carpal tunnel syndrome in your applied anatomy. So your teachers who teach you anatomy would have told you that as the median nerve goes through this tunnel, you have a carpal tunnel syndrome. What I want you to understand is carpal tunnel syndrome is a very, very common condition, and these patients are also going to present to us with varying degrees of wrist pain and their wrist pain, but their predominant symptom will be sensory symptoms in the hand, but they are going to come with varying degrees of wrist pain. And there are some tests of the wrist which when you do, you will be able to clinically make a diagnosis of carpal tunnel syndrome. So that's the main structure that we are bothered about on the volar side. And coming to the dorsal side, you can see all this chotu lot of tendons. You will appreciate that the nerves and the blood vessels are all on the volar side, but the dorsal side you don't have much of nerves and blood vessels. You have a lot of tendons on the dorsal side. So coming to the dorsal compartments, so these tendons are housed within synovial tendon sheaths. Why are these synovial tendon sheaths there? In fact, initially it is actually housed under the extensor retinaculum. So just like we have the flexor retinaculum, we also have the extensor retinaculum on the opposite side, and under the extensor retinaculum are all these tendons that are going to the dorsal side of the wrist, dorsal side of the hand, and passing on the dorsal side of the wrist. As they pass on the dorsal side of the wrist, you will notice that they are housed within synovial sheath. Okay, sheaths of synovium. So where is I'm sure you all heard of layers of synovium within the joint. So all synovial joints have synovium. Similarly, the same synovium is there around tendon sheaths, especially in places where they require to glide, and this gives a smooth gliding for the tendon sheaths. So all the synovial sheaths give the smooth gliding. So this is the medial side and this is the lateral side, because we have the thumb here, and similarly this is the medial side and this is the lateral side because we have the radius here. So from the lateral side to the medial side there are 6 dorsal compartments. Now there are no compartments like this, but I wanted to know that the extensor retinaculum sends septations inwards to produce smaller compartments, and thereby it is ensuring that these tendons are kept in different sets with specific functions. So why these things are important? I'm sure for your anatomy you must have with great difficulty tried to recall the fact that there are 6 different compartments, but for us for applied anatomy and for applied surgical importance, all of these dorsal compartments are extremely important. Okay, so the first compartment has got 2 tendons that are actually going straight to the thumb. So the extensor pollicis brevis and the abductor pollicis longus. So they are going straight to the thumb. So this is the first compartment. Okay, now what happens in the first compartment is, after the first compartment you have the second compartment where you have 2 tendons, that is the extensor carpi radialis brevis and the extensor carpi radialis longus. So they are these 2 tendons and they get attached here, and they are the prime extensors along with the extensor carpi ulnaris, which is giving the extension of the wrist. So when you have a radial nerve injury, you have something called a wrist drop, right? And this wrist drop is caused because of paralysis of the extensor carpi radialis brevis and the extensor carpi radialis longus on the lateral side, along with the extensor carpi ulnaris. So you have the extensor carpi ulnaris, which is the 6th compartment, that is here, ECU, extensor carpi ulnaris, and these 2 are the ECRB and ECRL. So that is the second compartment. Now we have a very good, very nice engineering trick being used here. We have a tendon that is actually an extensor. So this is an extensor pollicis longus. But instead of coming with the extensor pollicis brevis, the EPL has decided to go more medially and come. So what is the EPL trying to do here? The EPL is trying to give a more powerful extension. And to get a more powerful extension, what it does is it goes into the 3rd compartment. And I told you previously about something called the Lister's tubercle here. It winds around the Lister's tubercle. It takes the Lister's tubercle as a hook and uses the Lister's tubercle as a hook and tries to get a wider angle into the thumb. And by getting a wider angle into the thumb, it is able to extend the thumb much better than the extensor pollicis brevis. So that's a neat little trick of nature, and therefore your EPL is a 3rd compartment muscle. And in the 4th compartment, here we have the extensor digitorum extensor digitorum communis and the extensor indicis, and in the 5th compartment we have the extensor digiti minimi, that is going to the little finger, and in the 6th compartment, as I mentioned, we have the extensor carpi ulnaris. Each of these compartments also have got surgical significance. So the first compartment, these tendons tend to get inflamed. or the sheath tends to get inflamed, especially when it's going under the extensor retinaculum. This whole area can get inflamed. And when this area gets inflamed, we have a condition called dequervent stenosynovitis. I will show you what is dequervent much later. Okay, so having understood the dorsal compartments, now you will be able to appreciate the anatomical snuff box much better. So what is this anatomical snuff box? This anatomical snuff box is nothing but the gap formed here between the first compartment tendons and the third compartment tendon, which is the extensor pollicis longus. So that is the anatomical snuff box. And why is this anatomical snuff box so important? So in your anatomy, your teachers have definitely told you why the anatomical snuff box was called so. This anatomical snuff box is important because in the base of the anatomical snuff box, if you elicit tenderness, you are directly pressing on the scaphoid bone. So it's a wonderful clinical examination to examine a patient for a scaphoid bone fracture, or a clinical examination for scaphoid bone fracture. But it's definitely not so easy. That's because if you have a scaphoid bone fracture, then this whole area will be edematous, and the normal contour that we are seeing in this photograph will not be there. But having some idea of where the tendons are passing, you will be able to clinically appreciate the tendon or clinically palpate the tendon, and still you'll be able to easily figure out where the anatomical snuff box is. So what is the paradox here? The paradox is, when you really need to palpate the anatomical snuff box for a clinical examination of a scaphoid fracture, at that time the anatomical snuff box will not be seen because of the edema caused because of the fracture. However, it's a very narrow area and you can easily palpate the tendons because the tendons are superficial, and by palpating the tendons you will be able to figure out where the anatomical snuff box is, get to it and give a nice squeeze, and you will see the patient wincing in pain. So that's a very good indicator that you have a problem in the scaphoid. Okay, so with that I think I complete anatomy. Now I am sure you all have a nice base to understand the rest of the clinical examination of the wrist. So before we proceed to the wrist per se, I just want you to understand that these are the 6 functions of the hand. I'm sure this photograph is from one of my favorite books written in the 1960s or 1970s or something like that. So you will see that there is no mobile phone in the hand. These days the only thing that is held, or the only function of the hand, is to hold mobile phones. That's it. So you will not see a mobile phone here, but these are the fundamental functions of the human hand, and these functions are what makes a human different from primates. So that is very important, because these functions have given humans the ability to make tools. So if you study the history of humanity, you will realize that human beings basically became the dominant species on the planet because of only 2 reasons. The reason number 1 is because of their ability to make tools, and the reason 2 is because of their ability to collaborate. And now what do I mean by collaboration? Like for example, when you go to the animal kingdom, a group of chimps, which is supposed to be the most advanced form of life, will not be able to collaborate with anybody out of their group. So they have their group, they have their herd, they have their group or herd mentality, but they don't trust anybody. However, here I am sitting in this place here in Dharwad, and I am able to talk to maybe a dozen of you. I don't even know any one of you except Suhani. So in spite of that, I believe that you are all my students, and I also believe that you people are listening to this class with some amount of attention, and therefore that trust that I have in you and the trust that you have in me, that sir is actually giving us correct information, this is what is human collaboration. And this kind of collaboration will occur only in the human kingdom, and therefore these are the 2 things. So what are the 2 things that has made humans come to the apex of the animal kingdom? One is the ability of the hand to make tools using the functions that you are seeing on the screen, and second is the ability to collaborate. So those are the 2 things. So coming back to the functions of the hand, the first and the most important function of the hand is the ability to grasp. So this is the grasping function, this is the side pinch function. Because there is a key, so we also have a key pinch function. So it may not be a key, it could be anything that is flat, but it's a side pinch. Then holding with the tip, you have this function called the tip pinch. Then you have the chuck pinch, the ability to use a chuck, use the fingers as a chuck to hold on to something. A typical example would be the way you hold a painting brush. And this would be the hook pinch, where you use your hand like a hook. And finally the paperweight, where you actually hold on to something using the hand as a paperweight. So these are the fundamental functions of the hand. Now why am I talking about the hand? Because this is the pearl that I want you to take home today. Okay, you guys are at home only, but still the clinical pearl that you have to understand is the anatomy that we learned over the last half an hour. All those ligaments, those structures, those articular discs, all of those things are working to form the foundation for the function of the hand. Unless the hand has that foundation, unless the hand has the beautiful foundation of the wrist, the hand will not be able to do any one of these functions. Ask a person who has had a wrist pathology, ask a person who has had a wrist fracture, or ask a person who's had a wrist tumor. That person will tell you, my hand has never been the same again. So these fundamental functions of the hand is possible because the wrist forms the foundation for the hand to work. The hand is one of the most beautiful organs in the body, and for this organ to work, the wrist is what forms the foundation. And you people today, you're getting an opportunity to learn as a clinician, as a doctor, on how the wrist functions, as well as how, when a person with a wrist pathology or a person with a distress or pain in the wrist, when he comes to you, how you can help this patient by making a clean clinical examination and order appropriate treatment for the patient. So I tend to keep throwing these pearls once in a while during my class. I highly recommend you people to catch the pearls in time. Otherwise, they are just a waste. Right. So coming to wrist inspection. So for any joint, the basic way to do would be inspect the joint, palpate the joint, then measure the joint. What do you mean by measure the joint? Measure the movements of the joint and do a few other measurements, and then do some special tests. That's it. Orthopedics is very simple. It's all mechanical. So we will start with all the mechanical part of wrist examination. So what do you see here? You see a nice, in this inspection, I'm sure this swelling on the dorsal, or diffuse swelling on the dorsal side of the wrist is not normal. So this is the thing that you find out from inspection. What are the other things that you can pick up from inspection? So whenever you inspect a patient's wrist, that's your first impression of the patient. So one thing that I want you to understand is, like, the trick in clinical examination is to ensure that you get the complete confidence of the patient. So this happens normally within the first 5 to 10 seconds in the examination, where you are keenly observing the part to be examined. And as you're keenly observing the wrist of the patient, you know what the patient is observing? The patient is keenly observing your intent, and the patient is actually looking at your face. The patient wants to know how intense or how duty bound and how carefully this doctor is actually examining me. So when you inspect the wrist, basically what you see, you're looking at both the volar aspect of the wrist, the lateral side of the wrist, the medial side of the wrist, and the dorsal surface of the wrist. All around 360 degree you have to see the wrist. And then the next thing for you to do is tell the patient to keep the other wrist also outside, so that you will be able to compare the wrist. Because typically there will be a swelling, or there may be any change in the wrist, but you want to know whether it is a symmetrical swelling or it is a swelling that is present only in the wrist where the patient is having the pathology. When you are inspecting the patient, you are looking for swellings, you are looking also for dilated veins, you are looking for pulsatile swellings like vessels or aneurysms of vessels, and you are also looking for any scars on the wrist suggestive of any previous injury or previous surgery. You are also looking for any sinuses. They could be active sinuses which indicates an acute infection or an ongoing infection, or it could be closed sinuses which actually indicate that probably there was an infection and now the whole thing has healed and the sinus tract has sealed up. So these are the things that you are basically looking for. You're looking for swellings of the wrist. You're looking. Meanwhile, you're also looking at the skin texture. You want to see whether the skin is really, especially when it's swollen, it tends to be shiny and stretched. So you are looking for that. You're also looking for basically scars, sinuses, pulsations, and visible veins and visible pulsations. So these are the things that you're looking for, and you're looking for these things both dorsally as well as volarly. So here you're seeing if you notice, you will see a generalized swelling of the wrist. And which side is it? It is on the dorsal side. You also notice that this swelling is specific to the wrist as well as the distal radius and ulnar. However, there is no swelling in the going into the carpus. So that's a very important finding. So how do you know it's an important finding? This you'll come to know only when you come to final year, provided you have covered all your subjects and you have a good understanding of the subject. So then you will understand that this area, this kind of a swelling has got a different significance as compared to another kind of swelling where the entire wrist is diffusely swollen. So that is how it is. Now another possibility is you are again seeing a swelling, but this is a localized swelling. I am sure many of you would have seen this. So this is a very common condition called a ganglion. So this is a volar side ganglion and this is a dorsal side ganglion. However, let me admit that I am not at all qualified in calling it a ganglion, because presently I am only looking at a photograph, and so it is only inspection. Only after palpating the swelling, knowing the texture, knowing the consistency, and knowing the mobility and the plane of the swelling, will I be able to tell with certainty that it is a ganglion. Okay, so one more thing that I want to emphasize to you is, whenever in orthopedics we talk about localized swellings, we are expecting you from there to immediately switch to general surgery and bring out all the points that you have learned about examination of a swelling. So examination of a swelling is a big chapter in general surgery. So my student who comes to me, even if it's an orthopedic class, I would definitely expect this student to be able to do a complete examination of a swelling as per the protocols taught to you in general surgery. However, when a patient comes with a diffuse swelling of the wrist, there you don't have to bring in the general protocols of clinical examination of the swelling. Like for example, this is a diffuse swelling of the wrist. This here I wanted to bring in the protocols of the orthopedic examination. This is a diffuse swelling of the wrist. It is not a localized swelling, but here you clearly have a localized swelling. So what normally happens is, students come to orthopedics and they assume that we are going to see only patient with orthopedic problems. It doesn't happen like that. Patient doesn't know that they are supposed to come only with orthopedic problems to us. They sometimes come to us with surgical problems. And mind you, these swellings we also treat. Orthopedicians also treat, even general surgeons also treat. And the other differentials for localized swellings would be lipomas, and also another condition called neurofibromas, which are common in the hand. However, when you have these swellings coming from the wrist, around the wrist, localized swellings, the first diagnosis that you want to keep in mind is a ganglion cyst of the wrist. So that is what I want to emphasize to you. And the other thing about the ganglion cyst is that these ganglion cysts could be arising either from the tendon sheaths. You remember I told you that there are tendon sheaths around the tendons of the wrist, both on the volar side as well as the dorsal side. So these ganglion cysts may be arising from the tendon sheaths, but however they could also be arising from the synovium of the joint, in which case I told you the tendon sheaths is also made of synovium. So you can see the similar or you can see the connection here. The connection is that these ganglion cysts are nothing but localized outpouchings from the synovium, and therefore they can appear on the surface of the tendon, in which they are called ganglions of the tendon ganglions, or they could be coming from inside the wrist joint. And again, when it comes from inside the wrist joint, they are known as intra-articular ganglion. So the difference is intra-articular ganglion, and you have the extra-articular ganglion, which is coming from the surface of the tendons. The intra-articular ganglions tend to change their shape with movement of the wrist. So the one that you're seeing on the right side, there is a good chance that is intra-articular ganglion, and this also is a good chance because it's right over the joint. Okay, that's one thing. And the other thing is, it tends to get bigger and smaller as we change the direction or the movement as we move the wrist. So when you have an intra-articular, so it's in your clinical examination, you are going to differentiate whether it's an intra-articular ganglion or a ganglion arising from the tendon sheath. The typical feature of a ganglion arising from a tendon sheath is that you can actually move it laterally. So you can move it medially and laterally. However, you will not be able to move it in line with the tendon. Okay, so that is a typical feature. So in line with the tendon, it doesn't move. However, with movement of the tendon, the ganglions appear to move. So in other words, the mediolateral movement is possible, but the superior-inferior movement is not possible. So it clearly shows that it is coming from the tendon sheath or the sheath of the tendon. Okay, coming to this swelling. So there is something here in this swelling that maybe the picture is not so clear, but in this picture you'll be able to appreciate. You are seeing a swelling on the in the palm, as well as another swelling proximal to the palm, but in between there is no swelling. Why there is no swelling in between? Actually, it is a single swelling, but in between you have the transverse carpal ligament or the flexor retinaculum, and therefore the flexor retinaculum has compressed the swelling, and therefore this is called a compound palmar ganglion, and it is a typical of tuberculosis of the tendon sheath. So when you have the tuberculosis of the tendon sheath, then you will have a compound palmar ganglion. The characteristic feature is, when you press from here, this area tends to get filled, and when you press from here, this area tends to get filled. So that indicates that there is a connection, and that connection is connection through the carpal tunnel. Okay, so here basically on another inspection from the side, you are able to see that there is a deformity of the wrist. So I told you a few points that you have to look in when you are actually doing the wrist examination. So the first thing is that one of the things that actually I missed out was telling about looking for deformities. So this is where you look for deformity. This is a typical deformity that looks like a fork, dinner fork, and so it's called a dinner fork deformity, and it happens secondary to a malunited distal radius fracture. This is also another deformity of the wrist, where the wrist basically, this is the lateral side, so the wrist has gone into a valgus deformity, and this again is characteristic of a malunited distal radius fracture. Here you will see characteristically the radial, the ulnar styloid process, which is not supposed to be so prominent, has become prominent. That's because of the collapse of the radius, because of the radial distal radius fracture. So the ulnar styloid process becomes more appreciable as compared to the radial styloid process. Normally, the radial styloid process should be more appreciable as compared to the ulnar styloid process. And normally, the radial styloid process should be distal to the ulnar styloid process. Here you are seeing the ulnar styloid process is distal to the radial styloid process. So you can confirm this when you do the palpation of the radial and ulnar styloid process. So this is a congenital deformity in a baby. Again, here basically there is no development of the radius, and because of the mal-development of the radius, you are seeing that the hand is gone into a valgus deformity. And so again, here what I wanted to appreciate is not just the hand going into deformity, there is also a generalized curve of the forearm, but the focus here is on the wrist inspection because it's a wrist class, and I want you to appreciate the fact that the wrist has gone into a valgus deformity. Valgus means going away from the midline. Varus means coming towards the midline. Okay, so this is a classic inspectory finding in rheumatoid arthritis. So what you're seeing is, you're seeing a generalized swelling of the dorsal side of the wrist, as well as you're also seeing multiple deformities or multiple deformity. There is a swan neck deformity, the buttonhole deformity, and multiple deformities in the hands. So this is where I told you that seeing the wrist only will not give you sufficient information about the patient. You will also notice that the wrist swelling or the wrist deformity should be correlated with deformities in other parts of the body, especially in close by areas like the hand. So this will give you more information regarding the wrist deformity. Okay, so here what you're doing is, as part of your inspection, you are also going to look at the forearm muscles. Why the forearm muscles are important when you're doing the wrist examination? Because the power in the wrist or the mobility in the wrist. What is the mobility in the wrist? The palmar flexion, the dorsiflexion, the ulnar deviation, the radial deviation, all of those things are possible because of the muscles of the forearm. So the muscles of the forearm is what gives the power in the wrist. So this power in the wrist has to be will be maintained by the muscles. So if you have any disease or pathology in the wrist, then you will see that there is wasting of the forearm muscles, and this wasting of the forearm muscles will be better appreciated when you compare the forearm with the opposite side. So forearm wasting is a classic sign of either a wrist pathology or an elbow pathology. Okay, coming to another finding here, you're seeing that this person's thenar muscles are atrophied. Again, how do you say the thenar muscles are atrophied? By comparing it with the normal side. Again, this thenar muscle atrophy is a sign of some neurological pathology where and it is part of the wrist examination. Now, one simple rule of thumb that we do in the OPD setting would be to tell the patient to go and bring both his hands together. This is a very cursory way of checking whether the patient has got full dorsiflexion and full palmar flexion. Later on, we are going to measure the dorsiflexion and palmar flexion in measurement of the joints. However, here this is more like an inspectory finding. So here this patient, basically both the elbow tips should be at the same level. So how do you make the patient do this? You make the patient do this by showing him yourself by doing the same posture. But however, this patient has a problem. He does not have dorsiflexion in the right side as much as he has on the left side. So the left side is normal. So this is complete dorsiflexion, which is actually between 60 and 80 degrees as compared to the opposite side where there is a restriction of dorsiflexion. And because there is a restriction of dorsiflexion, the patient still knows that he has to do this. He has to bow his hands in the same way. So when he attempt to bow his hand in the same way, he will end up bringing the elbow at a lower level. So you are not going to tell him that, okay, your elbow is at a lower level, I found you. You're just going to observe this and tell him that, okay, fine, make a note of it in your mind that this patient has a restriction of the dorsiflexion of the wrist. The reverse for that. Here, basically, you are looking at the volar flexion. So here, when a patient has a deficiency in the volar flexion, on the left side, you will see it is normal for the patient. On the right side, you are seeing that the patient has got a deficiency in volar flexion. However, in his attempt to bring both the hands in the straight line, he will end up having to lift his elbow. So a lift in the elbow as compared to the normal side will clearly indicate to you that this patient has a deficiency in volar flexion. So these are simple inspectory findings. Now coming to a very important sign called the Volkmann sign. A Volkmann sign is a sign to look for tenodesis effect of the muscles. So basically you want to see whether there is any tenodesis or shortening or contracture of the muscles. So you will understand that the muscles are basically something like rubber bands. They tend to keep expanding and contracting, and they have that elasticity. However, there are some pathologies, chief of which would be something called a compartment syndrome, which will go into a ischemic contracture. So in a compartment syndrome that has gone into an ischemic contracture, you will notice that the muscles will not expand. The muscle will not does not have expansibility, and therefore you will notice that this patient, when his wrist is in the straight line or when the wrist is in neutral position, his fingers go into this kind of flexion, and you will not be able to open up his fingers. So that is because though the joints are normal, the muscle length is shortened. However, if the patient can volar flex, or if the patient can flex it in the volar direction, then you will notice that the fingers can be extended. So I'll show you another picture. Here again, in dorsiflexion, when the patient has dorsiflexed his wrist, the patient's fingers go into flexion, and any attempt on your side to open up this finger flexion will not be successful. However, if you allow the patient to volar flex or palmar flex his wrist, then you will realize that the fingers naturally open up. What does it indicate? It indicates that his joints are normal, but his muscle is contracted somewhere higher up, and it's a classic sign of Volkmann's ischemic contracture. And this Volkmann's ischemic contracture is secondary to a condition called compartment syndrome. So this whole sign is called a Volkmann's sign. Okay, now coming to palpation of the wrist. So when you take up the patient for palpating the wrist, first thing that you have to keep in mind is that you have gathered a lot of information just by inspecting the wrist. Now try to bring in all that information, because you are like really excited now to touch the patient. The first palpatory thing that you are trying to look for is you're looking for any local rise in temperature. So you're going to touch the wrist on the volar side as well as on the dorsal side, and compare it with the opposite side to look for local rise of temperature. So if there is a local rise of temperature, then you can be sure that probably you are dealing with an inflammatory pathology or an infective pathology. That is the first thing. Second thing is you are trying to palpate both the bony points and the soft tissue points around the joint. So in the wrist there are a few bony points which I will show you, the points that you are supposed to palpate. And what are you palpating this for? You are palpating this to look for tenderness. So what do you mean by tenderness? Tenderness is the condition in which on touching some part of the body by the clinician, the patient experiences pain. So that is tenderness. So whenever you are looking for tenderness and you touch the patient, you don't ask the patient whether it is painful. So we need to keep quiet, but we need to go on increasing our pressure in a gentle manner, in such a way that if at all it is tender, the patient will wince with pain. But you don't want to do it in such a way that the patient gets scared, and so therefore you're going to do it very gently, and slowly you're going to increase your pressure. The other thing is, from your clinical history as well as from your inspection, you roughly know the place which is inflamed or the place which is going to be painful, and therefore I would strongly recommend to gain the confidence of the patient, what you should do is you should palpate all the areas that are not painful, and that will help you to win the confidence of the patient. After winning the confidence of the patient, you can definitely go ahead and palpate the tender area. So what are the places that you want to palpate? The first thing that you want to palpate in the wrist is you want to palpate the radial styloid and the ulnar styloid. Apart from palpating the radial and ulnar styloid for any areas of tenderness, you also want to, now that you are touching them, you want to know their relative relationship. So the radial styloid should normally be distal to the ulnar styloid. So if you find that the radial styloid is at the same level as the ulnar styloid or at a higher level than the ulnar styloid, then you have a pathological wrist. The other thing is, I mentioned to you about the anatomical snuff box. You want to palpate the anatomical snuff box to elicit something called the scaphoid tenderness. So you want to know whether there is any injury or inflammation in the area of the scaphoid. The other thing that you want to palpate is you want to palpate the first compartment for tenderness. I again showed you the 6 compartments on the dorsal side of the wrist, and I told you that the first compartment there are 2 tendons, that is the extensor pollicis brevis and the abductor pollicis longus. So these tendons tend to go under the extensor retinaculum, and when they are going under the extensor retinaculum, normally they are supposed to have a free gliding movement, but here the free gliding movement is lost because of swelling and inflammation, and therefore you are going to palpate this area very gently to see for any tenderness in the first compartment. Coming to the TFCC, so I mentioned what is the triangular fibrocartilage complex, and I told you a lot of people, now you can see that this is a young patient. So similarly, a lot of medical students do approach me once in a while telling that they are having pain in the wrist, and on clinical examination I realized that it is a ulnar sided wrist pain. And this ulnar sided wrist pain basically occurs because of sprains in the triangular fibrocartilage complex. So the way to palpate it is go to the ulnar styloid. So here the examiner has gone to the ulnar styloid and just distal to the ulnar styloid, give a firm pressure. And to exaggerate the pain, or if the patient is not painful in this position, you can exaggerate the pain by doing an ulnar deviation. So this is how you elicit a triangular fibrocartilage complex TFCC tenderness. Okay, so the most important thing is coming to the range of movements, to examine the range of movements of the wrist. Because I told you the wrist doesn't have a great range of movements, but it's got sufficient range of movements to be able to do all the functions of the hand. So that is what it is. So the most important thing that I want you to know is the range of movements when you are examining for should be examined with the elbow in the flexed position. That is, the elbow should be at 90 degrees and the forearm should be in a pronated position to better gauge the range of movements of the wrist. So that is one thing that you have to understand. So whenever you are measuring the range of movements, you are going to do it in this position. Now this is something called a goniometer, and all medical students are supposed to have a goniometer for your orthopedic clinical examination. So we don't demand anything out of you, no stethoscopes and things like that, but you can definitely buy a goniometer for yourself and have all of you have your own personal goniometer. So it's a nice instrument that has got two limbs which allows you to keep it in the two different planes and measure the angles. So the measurement, everything is common sense. So here basically the examiner is measuring. If you notice, the examiner has kept the patient in the position that I described, and the examiner is actually measuring the volar flexion or the palmar flexion of the wrist. Normally the palmar flexion is between 60 and 80 degrees range. Now here the examiner is measuring the dorsiflexion of the wrist, and here the normal dorsiflexion. So how does the goniometer work? So I didn't tell you that, right? So the goniometer basically has got two limbs. One limb goes into one limb or into the hand. When you are measuring the wrist, one limb goes in line with the hand, then the other limb goes in line with the forearm. And the center of the goniometer should be at the center of the wrist. So how do you know the center of the wrist? If you are checking it on the lateral side, you are actually here you are checking it on the medial side, and therefore this sits at the ulnar styloid process. So that is very important. So you have to center it at the center of the wrist. So here the examiner has carefully centered it at the center of the wrist. So the centering is the most important thing. If you center it this side or this side, you will get wrong values. So this is the normal dorsiflexion of the wrist. This is between 60 and 70 degrees. However, in this position, if you force the patient can go for up to 90 degrees of dorsiflexion. So that is the range of dorsiflexion. Now coming to the ulnar deviation and the radial deviation. So now what you are seeing is the thumb is on this side. So this is the lateral side. So what the patient here is doing here is the radial deviation. The normal radial deviation is only 20 degrees as compared to this where the patient is doing the ulnar deviation, and the normal ulnar deviation is 40 degrees. Why is the radial deviation less? The radial deviation is less because the radial styloid is at a distal level as compared to the ulnar styloid, thereby limiting the radial deviation. And why is the ulnar deviation more? Because the ulnar styloid is at a higher level, and also because the ulnar is not directly articulating with any of the bones in the carpus. Now we know that all these movements took place in the wrist. When you actually check for movements in the wrist, you have to check for active movements as well as passive movements. So that is important. So if the patient has got passive movements, so first what you do, you check for active movements. Why do you check for active movements? Active movements are the movements done by the patient himself. So here what happens is when the patient is able to do active movements, it actually indicates that the patient's neurological system is also normal. However, if a patient is not able to do active movements, but if the examiner is able to move that area, that means the range of movements of the wrist is fine, but the wrist has lost the power, or the muscle innervation has been lost. So that is typically seen in patients who are paralyzed. So if you have a paralysis due to a central cause or a peripheral cause, you will realize that the passive movements are possible, but the active movements are not possible. So therefore, the first that we do is, first what we check for is active movements, and later on the examiner does the same range of movements. So for all these range of movements, you will also have to check whether it is active movements or passive movements. That is one thing. The other reason why we actually check for active movements first is because when you allow the patient to do the movement himself, if it is painful for the patient will not do the movements and therefore limit the movements. But if we go ahead and just grab the patient's hands and if we start doing the movements, then what will happen is the patient will have a lot of pain, and therefore the patient will start losing the confidence in the examiner. And once the patient sees the examiner as very rough and threatening, then the patient will start going into spasms, and the patient will start trying to protect himself. So that is important. Now coming out of the movements, now the next thing is the strength assessment. So what are the muscles that are powering, what are the movements of the wrist? You had a dorsiflexion, you had a palmar flexion, you had an ulnar deviation, and you had the radial deviation. Therefore, we are going to check the strength of these muscles. Why we are going to check the strength? Because it's part of the neurological examination of the wrist. And again, when you check the strength of the muscles, basically you are going to check the strength against resistance. And here there's a slight error. Basically, when the examiner is checking for the strength of the muscle against resistance, the other hand has to palpate the muscle belly to feel the contraction. So here the examiner seems to be stabilizing the forearm. So that if it's a single examiner, then that is not right, because this hand has to be going to the muscle belly and feeling the contraction of the muscle belly. So here there is an examination of the dorsiflexion of the wrist. Here reverse, the examiner is checking for the palmar flexion or the volar flexion of the wrist, or the strength of the volar flexion. And here the examiner is checking for the strength of the radial deviation, and here the examiner is checking for the strength of the ulnar deviation. So coming to a condition called carpal tunnel syndrome, I previously explained what is carpal tunnel syndrome. Carpal tunnel syndrome is basically an inflammation or a compression of the of the median nerve within the carpal tunnel. So that is what is carpal tunnel syndrome. And you will notice that the carpal tunnel pressures increase on dorsiflexing the wrist or palmar flexing the wrist. So continuous dorsiflexion of the wrist like this for up to 30 seconds will be done in the patient, because what happens is the patient who is symptomatic with carpal tunnel syndrome, typically the pain is extreme in the night, but the patient does not get to consult the orthopedic surgeon in the night. The patient would be coming the next day. So when the patient comes during the next day, especially in the early stages of carpal tunnel syndrome, most of the patients are pretty comfortable by the time in the morning or in the afternoon when they are consulting us. So at that time, this test basically is called is a test that will actually stimulate increased carpal tunnel pressures within the carpal tunnel. So by dorsiflexing the wrist or by palmar flexing the wrist for a prolonged period of time, that is between 30 and 60 seconds, if the symptoms that the patient experienced previously tend to come back, then the test is positive. So when you do the volar flexion of both the wrist, then it would be called a phalanx test. If you do the dorsiflexion of both the wrist and the carpal tunnel symptoms come on, then it's called a reverse phalanx test. Doesn't matter in which test is positive, as long as the patient's symptoms of carpal tunnel pressure reappear on clinical examination of the patient, the carpal tunnel test is positive. However, let me tell that during the late stages of carpal tunnel syndrome, this test is not of much significance, because the patient will anyway have symptoms of pressure of carpal tunnel in terms of burning pain, paresthesia and all neurological symptoms, both in the day as well as in the night. So there, in that stage, this test may not be very useful. Coming to the test for nerve compression. So here what the examiner is doing is, the examiner is trying to compress the carpal tunnel, compress the median nerve within the carpal tunnel. A prolonged compression of the median nerve within the carpal tunnel will cause paresthesia in the hand. So here the patient is doing the median nerve compression test, and here the examiner is doing the ulnar nerve compression test. So here you have, as you can see, the hand is much medial and it's in the hypothenar eminence, and there is a canal called the Guyon's canal there through which the ulnar nerve passes, and here by giving a sustained pressure on the ulnar nerve, we are able to elicit symptoms, pressure symptoms in the area of distribution of the ulnar nerve. The pressure symptoms that we are looking for is paresthesia. Okay, so this is something called a Finkelstein's test. So I told you about the condition called de Quervain's tenosynovitis. So de Quervain's tenosynovitis was inflammation of the tendons of the first dorsal compartment. So that is what we learned. And in Finkelstein's test, basically what we are trying to do is we are trying to stretch the tendons in the first dorsal compartment. So either you can grab the thumb and pull the hand in the ulnar deviation, and that will cause a lot of pain to the patient. The patient starts wincing. You have to do this test with a lot of care because it's an extremely painful test. So some patients whom I have tested in the OPD have told me that their pain increased by 2 times after they came for the clinical examination. So we don't want to do it on everybody. So the other way of doing it is the thumb is pinched into the fingers, and then the patient does the ulnar deviation himself. So you can actually pinch your thumb into your fingers like that, what this patient is doing, and you can also do the ulnar deviation. You will feel a slight stretching kind of feel, but there is no pain as such. So but in Finkelstein's test, it is a test for testing this inflammation of the first dorsal compartment. And I think no examination of the joints is complete without examining the ulnar artery, the vascular supply of that area. So radial artery, you know where to palpate the radial artery, and ulnar artery palpable in very thin individuals. So you can actually palpate the radial artery and ulnar artery also and report your findings. Mind you, every joint examination you will have to palpate the vessels distal to the joint. So if you are doing a shoulder examination, you are supposed to palpate the axillary artery, the brachial artery, the radial artery and the ulnar artery. If you are doing an elbow examination, you are supposed to examine the brachial artery, the radial artery and the ulnar artery. And if you are doing a wrist examination, you are supposed to examine the radial artery and the ulnar artery. It is not enough just palpating the radial and ulnar artery. It's also important that after palpating the radial and ulnar artery, you palpate the radial and ulnar artery of the opposite side and compare the volume of the pulse. That will tell you whether there is any deficiency in the volume of the pulse. So finally, you are also going to do an assessment of the median nerve, ulnar nerve and the radial nerve in the hand. So that would be totally different classes, and so I would not delve into that, but your examination is complete only when you do the assessment of these nerves, because these nerves are the ones that are actually powering not just the wrist but also powering the muscles of the hand. So then no clinical examination is of the wrist or of the elbow is complete without examining supination and pronation. I'm sure there are some smart students right here who would have actually thought, why sir is not telling about supination and pronation? Yes, so you're right. It's part of the clinical examination, both of the elbow as well as of the wrist. So what is supination and pronation? This is one of the most beautiful movements of the forearm. Basically what happens is, it's neither happening at the wrist per se, nor is it happening at the elbow per se, but it is happening in the area between the radius and the ulna. So the joints involved in supination and pronation are the superior radioulnar joint, so this articulation, the inferior radioulnar joint, this articulation, and the interosseous membranes. So this interosseous membrane itself is seen to be like a joint, because there is no synovium or anything, but it is held by fibrous tissue, and there is quite a lot of laxity, like how the joints have got the play. Similarly, just like how joints have a play, the interosseous membrane also has a play. Now you will notice that this is the process of supination or the anatomical position, and this is the process of pronation, what you are saying. You will notice from supination to pronation, the ulna is essentially straight. So ulna remains straight, but the radius does a complete 180-degree dance over the ulna, and from this end the radius has gone out to this end. So in complete pronation, it is the posterior side or the dorsal side of the radius that is actually visible. In complete supination, it is the volar surface of the radius that faces anteriorly. In complete pronation, the dorsal side of the radius faces anteriorly. So what you have seen is the radial styloid from here has taken an arc and come all the way down till here. So it makes a complete arc or a 180 degree arc, and this 180 degree arc is possible because the ulna is straight. If the ulna weren't straight, this 180 degree arc wouldn't have been possible. The other thing is the arc is also possible because here there is a connection between the radius and ulna. Here also there is a connection between radius and ulna. But here you see that the radius has got a curve, or this is called the radial bow. If not for this radial bow, then this 180 degree movement from the supination to pronation wouldn't have been possible. Therefore, whenever you have an injury of the superior radioulnar joint, or an injury of the inferior radioulnar joint, or the injury of an interosseous, or the injury of the radius and ulna in terms of fractures, then there is a good chance the patient will not have the normal supination and pronation that the patient had. And therefore, whenever I deal with a patient with a superior radioulnar joint injury or an inferior radioulnar joint injury or a radius ulnar fracture, my first and biggest aim is not just to heal the fracture and get anatomical reduction, but also my biggest aim is to get as much supination and pronation as possible. So that is the most important thing that I want you to realize. Now, I told you injury to the superior radioulnar joint. So can you give me, I'm sure you have examples of injuries to the, you've heard of something called a Monteggia fracture, where there is a fracture of the proximal ulna and dislocation of the head of the radius. So the head of the radius, which is in intimate connection with the proximal aspect of the ulna, now loses that connection and gets dislocated. So that's an injury of the superior radioulnar joint. Similarly, we have a condition called a Gillespie fracture, where there is a fracture of the radius along with disruption of the inferior radioulnar joint. And there again, unless you fix the bone anatomically, you are not going to restore the distal radioulnar joint articulation. And if you don't restore the distal radioulnar joint articulation, then the patient loses the complete or loses full range of supination and pronation. Now, having understood the bony structure, it's also nice if you can appreciate the muscles that are causing this supination and pronation. So the first and most important pronator of the forearm is the pronator teres, followed by the pronator quadratus. So you can see the pronator teres from here, it's attached all the way to this side or the lateral side of the radius. So when this muscle contracts, you'll see how beautifully the radius moves from this end to this end, as you can see in this picture. Same thing with the pronator quadratus. The supination is mainly brought about by the biceps along with the supinator muscle. Now, for a better understanding of what is supination and pronation, this I want you to understand is the normal anatomical position. So here what you're seeing is, you're seeing that his elbow is flexed to 90 degrees and his wrist is in neutral position. So this is a neutral position. From the neutral position, this is the supination. So the normal supination is 90 degrees. So you can see his thumb from here has moved to the lateral side. And the normal pronation is again between 80 and 90 degrees. His thumb from this end has moved from the lateral side, the thumb has moved to the medial side. This is the normal pronation. Now there is a small error in this photograph. You will notice that here his hands are by the side, his elbow is by the side of the body. So whenever you are checking for supination and pronation, it is very important that you tell your subject that the elbow should be touching, or the medial side of the elbow should be touching the body. That's important because if the elbow is not touching the body, then your measurement of supination and pronation will be erroneous. As you can see, this picture is perfect, this picture is not perfect, and this picture is also not perfect. When he went into pronation, he actually slightly took off his elbow from the side of the body. So I just want you to understand once again that whenever you are checking for supination and pronation, the medial part of the elbow should be in contact with the body. And for us to actually get an idea of how to keep the scale, so what is done in this picture is a pen has been given into the patient's hand. So as the patient grasps the pen or a pencil, then you will notice that it's very easy to examine supination and pronation in terms of angles. The other nice way of doing it is by giving two pens in both the hands. So as the pens are there in both the hands, you'll be easily able to see the difference in the position of the pens. And by seeing a difference in the position of the pens itself, you will be able to tell that the patient has got a deficiency in supination, or if the patient has got a deficiency in pronation. Only thing that you should take care is the pen or the pencil should be of the same size, preferably of the same make, and held in the same position in both the hands, which will give you the uniformity in terms of your final conclusion. Now I'll tell you why the elbow had to be close to the body. Now you will notice that this subject does not have complete pronation, but she can make up for this loss of complete pronation by gently abducting her shoulder. So it's so easy. So the abduction of the shoulder helps in making up for the deficiency in complete pronation. So similarly, if the patient does not have a complete supination, the patient can adduct the shoulder. But you can understand, adducting the shoulder is not so easy. So try adducting your shoulder and try abducting your shoulder. You will notice that abducting the shoulder is much easier than adducting the shoulder. And therefore, since adducting the shoulder is difficult, I want you to understand that deficiencies of supination are tough to make up as compared to deficiencies of pronation. This is the same reason why I told you that your examiner or your subject has to have the hand that is the elbow by the side of the body. So that I think completes supination and pronation, and I think with that we come to the end of the clinical examination.